Good morning, everybody. This is Louise at O'Neill Marketing, and I just wanted to welcome everyone today as we have our O'Neill Marketing Summer of Training series continuing. We know that self-confidence and understanding your product is key to success. And so we are offering webinars Tuesdays and Thursdays throughout the summer to make sure our agents understand the products they are selling. Last week, we explored some group products and are continuing that this week. Next week, we will move on to Medicare webinars, and we'll follow that up with ancillary webinars, followed by some ACA top carrier webinars. Today, we are excited to welcome Ryan Churchill. He's with Centivo, and Ryan will talk to us about this product that allows employers to save money using self-funded programs. As we listen to Ryan, we encourage you to type in any questions you might have along the way. And at the end of the webinar, we'll leave time for your questions and answers. So thanks, Ryan, for joining us today.
Absolutely. Thank you for having us. And what I would like to do is just kind of give everybody a good overview of what it is we're doing here at Centivo, and really kind of arm you with the tools to make you dangerous. If you have a prospect or an opportunity that comes up, I will be the main point of contact. I'm actually based in Tampa, Florida, and I cover the whole Southeast region, and we'll get into a little bit about our regions, but typically, well, right now that's our Orlando market and our Greensboro, North Carolina market. And what I want to do is I'm going to dive in, but before I do, I just want to introduce my team. I think we've got Tucker on and Andrea. If you guys just want to give a brief introduction of yourselves.
Sure. Good morning, everybody. My name is Tucker Niewick. I am the East Region Sales Leader for Centivo. So work closely with Ryan and Andrea, who's also on the phone, to support you all in your prospecting or existing clients and presenting and implementing the Centivo solution. So pleasure to meet you all and looking forward to our discussion this morning.
And hi, everyone. Andrea Markowski. I am on the sales team as well, and I work largely in the Northeast, supporting the sales execs like Ryan and the others on the East Coast with the more technical aspect of the product, with our plan design and implementation and network strategy and things like that. So excited to talk to you all today.
Perfect. So we're going to do a little overview. We're going to talk about the model. We're going to talk about how it is we do what we do. And then we're going to kind of give you an overview of where we are now and where we're going. And then we're also going to give you a demo of our employee model. So what the actual app looks like and how that's going to look. And then like we said, we'll open it up to some questions after that. Okay. So I'm going to go ahead and I'm going to let Tucker go ahead and get us started.
Great. Thanks, Ryan. And really the goal of this slide here is just to demonstrate that this is a little bit of a different model when it comes to marketing and the way that companies are viewing their employee benefits. So it will require, or the approach we've taken is it's a little bit of a different distribution approach as well. And so with Ryan, what we're trying to identify are those core key partners that are really looking to grow aggressively, are comfortable with non-carrier models, working with TPAs like Centivo, and really understand that the key to unlocking cost savings for both employers and their employees is understanding and taking advantage of the differentiation in cost and quality metrics that exist within key markets. And we'll show you where we are today with that. So this is a self-funded solution for employers that are typically over 100. There is some flexibility in the Florida market for companies that are under that 100 employer threshold, or excuse me, employee threshold. But we just like to call out that we are looking to identify those partners that are comfortable and kind of fit within these key characteristics as we go out to market and start to aggressively show off our capabilities. So if we move to the next slide there, Ryan. So as we all know, the reason that Centivo exists and other solutions are emerging in the marketplace today is that healthcare is broken in this country, and specifically employer-sponsored healthcare. It's becoming too expensive for most Americans, where the average deductibles and cost shifting. Average deductibles have increased over time as cost shifting has increased in frequency as well to help mitigate some of the expenses for employers. The costs continue to rise while wages have also remained stagnant over the past 35 years, even though healthcare expenses have doubled in that same time frame. And despite the challenges that the average employer faces and the average employee faces in this country, the stock market has gone up 175% over that time. Carriers still continue to reap the benefits of as well, despite the challenges that employers and employees are facing. And so with this in mind, Centivo was founded with the mission of bringing affordable, high-quality healthcare to the average American employee that struggles to pay their healthcare bills every year. And the way that we've approached, or the approach that we've taken to doing that is looking at strategies that have worked in other aspects of the healthcare space. So how do we take advantage of the models that are already working today and implement them into one model that, again, aligns purchasers, employees, and high quality healthcare providers to really drive cost and quality for the average American? And so it's taking things like coordinated care, working with a primary care physician to really help navigate the healthcare system. As I said in the kickoff slide, how do we take advantage of the fact that there are high variations in costs with no correlation to quality? And the fact that as more and more point solutions emerge to help employees navigate the system, the reality is most employees are still relying on that trusted advisor, on their doctor, not any transparency tool to really help understand and navigate the healthcare space. And so as we move into what the Centivo model looks like, borrowing from all of these key strategies and approaches, what we've done is built a new health plan that is centered around leading providers of value-based care. So what does that actually mean? What we've done is we've built and contracted proprietary networks centered around high-value systems that are focused on primary care as a means to navigating the healthcare system. To make the network appealing to make our proprietary network and the primary care centric model appealing to members, we've partnered that with a plan design that is very easy to understand. So there is no deductible, free primary care, and co-pays for all other services. So it's affordable, and most importantly, it's predictable. So the members know exactly what their costs are going to be every time they receive care or access services. And additionally, we've paired that with a member experience that Ryan mentioned we are going to demo for you just so you can see what it looks like. But again, reinforcing this idea of coordinated care and of working closely with their primary care physician to navigate the healthcare system. So at our core, and so that's what we're doing that differentiates us from other plans. Really at our core, we are a TPA, so we are administering, adjudicating claims, we're answering the phones through our concierge team, we are providing reporting and analytics through a partnership as well. We have access to broad networks, and we're going to talk a little bit about what's unique about our arrangement with our partner Cigna, so the ability to access their national PPO, OAP, and local plus networks. As well as additional wrap networks, that you might be familiar with, like First Health or MultiPlan. And then lastly, and I think fundamentally, our approach is to be fully accountable and transparent down to the last penny. So we are not making any money on out-of-network shared savings, on stop loss, on pharmacy solutions, all of that, and we believe fundamentally, in order to be completely aligned with our clients, we tie our fees to an administrative fee and then a performance fee based on total cost of care, with upside and downside risk for us as the administrator. So if a plan performs well, then we share in a small piece of those savings up to a cap. If the plan doesn't perform well, then we are giving back a portion of our administrative fees, again, because we believe that it's important to be completely financially aligned with our client base. And so that's the overview. We are going to get into the specifics of each component that I referenced, whether it's the proprietary network, plan design, TPA operations, but that is what we are doing at a 30,000-foot view. So if we move into some of the components of the plan, you can see here I mentioned we do have a relationship with Cigna that gives us the ability to offer our proprietary network and what we call the partnership plan side by side with their broad access networks as a point of enrollment decision for employees. So what we typically recommend in our view on this is that you want to offer the partnership plan using our network, requiring primary care attribution and referrals to see a specialist. But the trade-off for those criteria is that they would have a plan that has no deductible, free primary care, and co-pays for all other services under the plan. Again, the idea that this type of plan design incentivizes partnering with the primary care physician, it eliminates any barriers to accessing care at the primary care physician level, and it provides that predictability that employees and members are really looking for in this world where deductibles and coinsurance amounts and bills being received later and not knowing what the cost is going to be for accessing care tend to steer people away from utilizing healthcare services.
Hey, Tucker.
Yes.
This is Chuck O'Neill. Can I just make a comment and I'll get back off? But this no deductible thing is huge, huge. I mean, I look at this and I'm thinking people have an out-of-pocket max and they have co-pays, but not to have a deductible is amazing. I'm very impressed.
Oh, thank you, Chuck. Really appreciate that. And again, that's been the biggest findings from our existing book of business and those that are participating in this plan is this idea of, again, the predictability, no deductible, no barriers are really what is getting people or members more, that's the reason that they're choosing this plan. Additionally, what we are also doing for those that are either receiving care at a system outside of our network or don't want to work with a primary care physician, want direct access wherever, again, that's where the Cigna network comes into play. And what we typically do to minimize any disruption is mimic the existing plan designs. So again, employees that are comfortable or satisfied with their existing benefits still have access to them, still have access to the systems through the broad Cigna network as well. So just want to highlight again, as a self-funded client, there's unlimited flexibility in how that you as the consultant or the company can structure their benefits, including on the partnership plan. Again, really, we strongly recommend, or I don't want to say require, but we almost do because we feel that strongly about it. And Chuck, to your point, is this idea of no deductible free primary care and the predictable copays. So moving to the next slide, we're going to transition a little bit into the network construction and how we identify partners that we want to open a geography with. And really, these are kind of the core tenets for systems that we tend to contract with. So the first and most important to us is that primary care has to be at the front and center of these systems. And they need to be practicing team-based medicine. So meaning that there are registered nurses or physician assistants embedded within the practice to assist the primary care physician with seeing their patient panel. We also think it's really important in terms of coordinated care that these systems have a common electronic health record or technology platform so that notes or clinical notes can be passed and shared between primary care physician, specialists, facilities, so that, again, the primary care physician can really act as the quarterback for accessing care. When we talk about building for access or being built for access, we really are also trying to change the definition of access from the way that people have traditionally viewed it. So it's no longer about how thick the provider directory is. It's about making sure that members can see a doctor when they need to access care. So things like having an embedded virtual care solution within the system that the employee or the member can access, having an online patient portal or a communications platform that reaches out or follows up or makes sure that their care is coordinated, making sure that contractually through our direct contracts that if a member needs to see a primary care physician before 10 a.m., they have guaranteed access that same day, or same week access for a specialty visit. Those are all things that we think are hugely important, especially when you are creating a model that's centered around primary care. And lastly, we want to focus on those systems that have experience in risk-based contracts. So those that have invested in the capabilities and in the Medicare space to take advantage and constructed ACOs to take advantage of upside risk, and are now looking to deploy those same resources into the commercial population. So really all we're doing is looking for systems that meet this criteria and then trying to build upon those capabilities, whether it's clinical adequacy or geographic coverage, but again, trying to work with those systems, meet them what they are, and continue to enhance their capabilities, as well as fill out the geography and contract with other independents that may fit certain criteria. So if we move to the next slide, Ryan, just to give you an overview or a view of where we are today. So in the Southeast, we have Orlando is our core geography or our key partner in Central Florida, as well as Cone Health in Greensboro, North Carolina. Additionally, we have established markets in the Northeast, so extending from Hartford, Connecticut down to Philadelphia, Pennsylvania, Southern California, so LA and San Diego, as well as Iowa and Nebraska. Additionally, we are in the process of building out markets in the Pacific Northwest, Dallas, Fort Worth, Kansas City, and Wisconsin. And again, this is for 1/1/22, so we expect those markets to be completed by that timeframe for effective dates. And then, an aggressive growth strategy over the next 2 to 3 years to continue to fill out this map and hit major MSAs throughout the country. Since I know a lot of folks are based in Central Florida, we do want to give you some additional details about that market. So again, as I mentioned, Orlando Health is our foundational partner in Central Florida. You can see the MSA in Orlando covered here, as well as extending out to Daytona Beach through contracts with Halifax Health. Additionally, we also have facilities and doctors in St. Petersburg, and that's through the Orlando Health acquisition of Bayfront Health. So we do recognize that there is a gap between that Tampa to Orlando corridor. It is a priority for Centivo to build out that network, but just want to highlight, again, that is not something that will be available for 1/1/22. Though, again, it is something we are working on potentially for 1/1/23. And with that, I'm going to pass it over to Andrea to walk through some of the financial levers on how we are able to save, 15 to 20% for companies that utilize this model, and the approach we take, and again, why a company would consider investing in this solution and going through the change management compared to their traditional model. Andrea?
Yep, thanks, Tucker. So like Tucker said, just to go through a little bit more in detail how we actually save money. So it's really 4 key levers which are displayed here on the screen. And it starts with simply the aspect of care redirection, which Tucker talked about a little bit earlier in the presentation, which is simply the idea of taking care that's currently being received at costly and inefficient health systems and shifting it to partners in certain geographic regions that we have chosen that are both high quality and cost efficient. So many of these health systems that we partner with have qualities such as advanced primary care centered models. They have patient access and experience guarantees, and they're also and they do value-based payments tied to primary care centered management. And the last aspect that we look for is that they're already unit cost leaders in the market. And then through excluding their competitors, which moves on to the second lever there, we are able to then have even further discounted savings from a unit cost perspective, because we're going in, we're seeing the high cost health systems and we're removing them from our network. And from that, we're able to have even steeper unit cost savings. So even though we don't have the memberships that a lot of the larger carriers might have, all of the members that we do have are being steered towards the health systems that are within our network, which is how we're able to achieve those savings. And then the bottom two levers really focus more on the aspect of that tight primary care model. So having that PCP is really meant as a guide for the members and not to be any type of gatekeeper or burden to them to have that referral. And we really just want them to work closely with their PCP to help navigate them through the often really complex healthcare system. And through this relationship, we see an increase in primary and preventive care. And then on the back end, a decrease in unnecessary urgent care and emergency spend, as well as unnecessary specialist care. So when patients do have a problem, they're not going to Google and trying to self-diagnose and making an appointment with a really costly specialist. They're first consulting their PCP to see if it's actually necessary, which is where that fourth step of intelligent referrals comes into play. So when referrals are needed, the members are working with their PCPs, and then our PCPs are referring really intelligently inside their medical neighborhood to specialists that have been vetted by third-party data sources as well as Centivo. So this slide here goes into a little bit more detail on those unit cost savings and how the aspect of care redirection really works hand in hand with unit costs. So we have just a few health systems in the Northeast specifically that we're going to focus on for this slide. So if we look at the top, we have New Jersey, and the bottom is New York. So hospitals E, F, and G are all Centivo partners, and hospitals H and I are systems that we have excluded from our network in the New York area. So if we focus on these bars, you can see that already that teal bar is the current market rate, which hospitals H and I in this case are already nearly double from a unit cost standpoint before we're even contracting and further reducing those discounts. And then the dark blue bar there, we can see for E, F, and G, through excluding those competitors, we're able to then have that even deeper discount from a unit cost perspective. And if we move on to the next, so this is an example of a savings analysis that Centivo is able to put together for any specific prospects that we might be working on, just to kind of go into more detail on what the specific savings might look like on a client-to-client basis. So with just some simple PMPM data broken out on an inpatient, outpatient, and professional basis, we're able to show on a line-by-line standpoint how we're actually able to change the underlying claims distribution without cost shifting. So you can see here we have that aspect of redirection and unit price coming into play, and then that PCP management impact as well. So even though we are making that investment in the plan design where we don't have deductibles and the member cost share is a little bit lower, and we also do anticipate seeing a bit more PCP visits, we still are able to realize a net savings to the plan, which in this case is 17%, through those things that I touched on earlier, such as the decrease in ER and urgent care, decrease in inpatient and outpatient spend, as well as miscellaneous spend and unnecessary specialist visits. So this just gives an example of some of the savings that we've actually seen so far with our clients. So if we just start on the left-hand side here, average healthcare costs for a family of 4 are on an annual basis around $26,000. So this is all in costs. It includes the out-of-pocket costs that members are paying at the time that they're receiving service. It includes what they're paying out of their pocket from a monthly contribution standpoint. And then it also includes what the employer is contributing towards their healthcare. With Centivo, we're able to reduce those annual costs to around $21,000 for a family of 4, which is on an annual basis approximately 29% for the family in savings and 15% for the employer. So this just demonstrates how it really is a win-win for both the member and their family as well as the employer. It really helps. It helps both without that aspect of cost shifting coming into play. And then going to pass it over to Ryan to walk through this slide, and then as well as some information on our open enrollment materials and the member experience demo.
Thank you. Yeah, so what we've done, the plan requires employees to elect a primary care physician, right, a PCP. So what we've done, and we're actually piloting this in Florida. So Florida would be the only market that this product is currently available to, and we just rolled it out July 1st, is the ability to have a virtual primary care physician or a virtual PCP. So what we've found is that 80 to 85% of all primary care can be done virtually. So giving our employees the opportunity to just elect this for convenience, or if maybe they're on, the outskirts of our geographical territory there, just to give them the ability to get this stuff done virtually. It's a much simpler and easier experience for the employees. And then also when it comes to our materials, so we have very clear communications. We've got a lot of great open enrollment material, a lot of custom stuff that we create for our employees that are part of the plan. And then we also have a demo, and I'm going to stop sharing here for a minute, then I'm going to pop back on the demo. All right, can everybody see this?
Yep.
Perfect. All right, so this is going to be the actual, app that an employee is going to open up when they elect a partnership plan. So they'll have a open enrollment. They'll have the opportunity to, elect Centivo or elect Cigna. And if they elect the Centivo plan, we'll gather all their information. We'll send it off. We'll load it up into the app, and then employees are required to do what's called activating the plan. So basically that means electing a primary care physician. So employees will download the app. They're going to go ahead and they're going to set up an account. And we're going to go through, and as they do it, the app is really built around communication, educating the employee on not only their choices, their options, but also their plan design, how it works, what the capabilities are. And then on an ongoing basis, it gives them a lot of resources to really empower them to utilize their plan. So this is going to be the screen that they see here. As soon as they open it up, some of their information is already going to be pre-populated into the plan. We're going to go ahead and hit Add a PCP. All of Serena's dependents are going to be loaded in here. We're going to go ahead and select a primary care team. Now, some people are already going to know who their primary care physician is, so they can have the opportunity to do that. If somebody doesn't have a primary care physician, go ahead and hit here. And it's going to give you a couple different options on some requirements for a primary care physician, whether it's geographic distance, accepting new patients, different types of specialties, gender, and allow them to kind of pull up a whole search result of physicians. So we're going to go ahead, we're going to hit Eastside Primary Care. And when you hit that, it gives not only some information on the physicians, but also their clinical support teams. So we're going to select Michael Carlisle. We're going to choose this provider. And then you can see here, immediately it assigns Michael Carlisle to Serena, the employee. Now, if you have dependents that are maybe in a different network or out of network, you have the opportunity to pick their own primary care team. But just for convenience today, we're going to go ahead and we're going to add Michael Carlisle to everybody. We're going to go ahead and save and complete the activation. And then it gives you the opportunity right off the bat to go ahead and schedule a visit. So we've got two other kind of call to actions here. So learn where to get care. Remembering that this plan is all based around your primary care team. We feel like most care can be provided by the primary care team and then intelligently referred out to high value specialists. So when to go to urgent care, when to go to the hospital for a serious emergency, and when to see your specialist. And also when to do, what to do if you're doing something out of network. So then it gives you a couple of questions here. Just to really kind of hammer home the knowledge, how the plan works, and what you need to do. and then it takes us back to the home screen. And then it also has the opportunity to review your new benefit coverage. So we're going to hit that. So again, breaks down whatever that plan design is, emphasizing again, no deductible, free primary care visits, and then all the copays. Also gives you the opportunity, kind of some frequently asked questions that we see a lot. You know, what is a deductible? What is an out-of-pocket maximum? It gives you the option to kind of do all this. Again, a couple of questions to sort of reiterate the actual plan design and how it works. So now you're back at the home screen here, and this is going to be the screen that an employee typically sees throughout the year. So you have a couple different things you can do. You can go in here, you can look at more information about your primary care team. If you want to change the primary care team, you can do it through the app. If you have any messages, either from your primary care team or outgoing, maybe to the Centivo concierge team, which is our kind of account management team. You have the opportunity to get that there, as well as referrals. If you go see your primary care physician and they refer you off to a cardiologist or orthopedics, you have all that information saved in the app that you can get to, as well as ID cards, right, front and back. So it's a really good experience. Employees, the feedback we get is very positive, and it's a very simple, easy to use, and it empowers the employees to really go through and take advantage of kind of the resources, the technology that they have. So one of the other things we have here, this is kind of an example of a group we sold up in the Northeast. It's a 1,500 employee regional grocery chain, large grocery chain. They were looking for a new solution. They were tired of getting that same renewal every year. You know, it comes in 15%, the broker consultant negotiates it down to a 9%, and then they just kind of eat it. So they were looking for something different. They reached out to us, and we were able to kind of put in the Centivo partnership plan. And what we've seen has actually been quite remarkable. So about 50% of the employees actually elected the partnership plan. It's shown a 35% decrease in the overall cost, and that's everything that goes into that. And then an 81% reduction in member out-of-pocket costs. So remember, free primary care, no deductible, and then really easy to understand and anticipate copays for specialists. So we make it very simple. And I'm going to let Tucker talk a little bit about this.
Yep. So again, this is just meant to demonstrate or give you more examples of that, you know, the transparency that we think is critical when working with companies that are utilizing our services. So again, our fees are structured in a way that are fully transparent. So we're not playing any of the games that, you know, some of the carriers play today with out-of-network shared savings or pharmacy or rebates or, you know, stop loss fees being embedded in the stop loss premium. You know, we are charging typically a base fee, and that's an administrative fee on a per employee per month basis. We do have, you know, the market standard operational SLAs that we include in that, like turnaround time on claims processing, et cetera. But the other component that we typically offer in our fees is performance. So, you know, going at risk from an upside downside perspective on fees that are tied to total cost of care. So again, you know, if the plan performs well, then, you know, we get a piece of the savings up to a cap. If the plan doesn't perform well, then we're giving back a portion of the base administrative fees that we are charging, again, because, you know, we want to be completely financially aligned with our clients. So something we think that's a little bit unique in the market, and you know, certainly think it's important to make sure that everybody is working hard together to help drive down the cost of healthcare for employers and their employees. And so if we look at a typical sales process, we did mention, and I mentioned at the outset that this is a bit of a different model than companies are used to. So we do think it is important that we get in front of decision makers, HR, CFO, whoever it might be, early on in the process to help demonstrate or explain our value proposition. So when we're looking at identification of clients and prospects, some of the key components that I referenced earlier, they have to be self-funded or willing to look at self-insurance or moving to self-funded. They have to be open to a non-carrier solution. So, the willingness to or comfort level to work with the TPA. There also typically has to be a business imperative for change. So this is going to be different than an approach that they're used to. However, again, it's and they have to be willing to make that investment in change management and some potential disruption for employees in communicating this different message. So a willingness, to either change due to affordability or cost savings issues, again, that employer model or those that Ryan mentioned earlier are a little bit more innovative, tired of the same process every year of negotiating double-digit increases down to single-digit, et cetera. We do think it's important to have engagement at the C-suite level. So identifying those companies and CFOs or CEOs that may be a bit more involved in the decision-making process. And then I think fundamentally, they need to have a strong network match within the core geographies that I outlined earlier. So we typically look for 50% as kind of the threshold. However, anywhere from 30 to 50%, we do think that there is enough value in the financial levers that Andrea mentioned to again be willing to make this type of move. From there, we can provide you, once we identify those clients or prospects, or if you have a couple in mind, we do have some reports and analytics that we can provide. So depending on the timeline or what the group is looking at, we can generate a savings analysis if we have some PMPM data. Based on inpatient, outpatient, and professional services. We can run a network match analysis to identify the percentage of employees that fall within our proprietary network geographies. So that's just with a simple zip code census file. We can provide geo access reports. So these are all the types of things that we can do in addition to providing the analytics from Cigna on their network. What we typically also try and promote is this idea of a joint concept meeting. So again, walking through the value proposition of our model, providing the analytics and analysis that we can turn around from a geo or census mapping or savings analysis. And then if they are bought into that concept, are willing to move to a self-funded model, then that's where we can work with you all to get stop loss and provide a full proposal for their review. So we're looking at a typical group. Again, this is our preferred approach. So for a 1/1 effective date, making sure that we have enough time to effectively implement with decisions by September 1st. That said, we can constrict that timeline down to 60 days, recognizing again that's not ideal. But it is a capability, and there may be some potential disruption in terms of ID cards and things like that. But this is a typical approach. Again, we do think it's important to get out in front early with the concept meeting with you and the client. But happy to answer. I think this is the last slide, so it looks like we have some questions in the chat here.
Yeah, I see him here, Tucker. I'll kind of read that first one off if you want to. I'll tee it up for you. Do you guys have the ability to do reference-based pricing on the Centivo plan, or do you have direct contracts based on Medicare reimbursement for your in-network hospitals?
Yep. So a great question. I would say we do have. Let me start over. So with our direct contracts, we are not able to offer reference-based pricing at the systems where we have our direct contracts. So that's part of our agreement. However, our fees at those in-network hospitals are typically, I would say, in the range of where most RBP claims are being settled at. So, it's not going to be 120%, but it's also lower than 200% typically on an inpatient basis. So, what we typically see is that our direct contracts are going to provide comparable savings to an RBP program, but without the employee disruption. That said, what we can do, and I showed, or Ryan showed the partnership plan design. What we can offer is essentially an out-of-network benefit level. So for all benefits or all services that are rendered in-network at our directly contracted providers and systems, they would access, or they would have that richer benefit design. And then on an out-of-network basis, we can offer a deductible with co-insurance, and it'll look like a traditional out-of-network benefit, and we can have that set at a Medicare reimbursement level. So those are the types of things that, as a TPA and being flexible, we can offer, but we cannot intermingle RBP with our direct contracts. We can administer, and we do have partnerships with RBP vendors, so we can be a traditional TPA offering RBP, but we just can't intermingle with our direct contracts. Looks like the next question, are you doing anything with no medical questionnaire technology? So yes, we do have partners that access systems like Verify or GRX. So there are some workarounds in the smaller market for those companies that don't have access to data. That said, it's the reason we say 100 plus is there's typically going to be a little bit more access to data, but we do have partners on the stop loss and reinsurance side that have access to those capabilities. We just can't guarantee that we'll be able to pull together a proposal. And as we all know, it all comes down to the stop loss. Is it possible to get a copy of these slides? So yeah, we're happy to share the slides, and Ryan will put together a PDF of these, and we can follow up with you directly as well if you have any direct questions, and happy to provide these to you.
Wonderful. I think that's all the questions we have. But I want to thank everyone for tuning in today, and special thanks to you, Ryan, Tucker, and Andrea, for updating us on the self-funded programs available through Centivo that are both flexible and more affordable for employers and their employees. Please be on the lookout for a summary email today that we will send out to all participants. If you have a group looking for insurance, we ask that you contact Chuck O'Neill here at O'Neill Marketing. And if you are not a current agent with O'Neill Marketing, we would like to sign up, we would love to talk to you. As a reminder, we hope you will join us for our next webinar, which is this Thursday, July 9th, with National General, another provider of group insurance. And that webinar will also be at 11 a.m. Eastern Standard Time. So thanks again, Centivo, for joining us. We really appreciate having you with us today and educating our agents on the programs that you offer. I hope everyone has a great day. Take care.
Thank you.
Thank you.